Welcome, everyone. In today's training, we're going to walk through the specific changes CMS finalized for the 2026 MSSP performance year that affect how our ACO reports clinical quality metrics under the APP Plus measure set. The APP Plus set remains stable at 5 clinical outcome measures and 2 administrative claims measures, but CMS made several updates that impact screening workflows, documentation requirements, denominator logic, and measure specifications. By the end of this session, each of you, whether you're a clinician, care coordinator, QI lead, or reporting analyst, will know exactly what's changed and what adjustments we need to make going into 2026. This first measure is diabetes, glycemic status assessment greater than 9%, also called Quality ID 001. This is an inverse measure, which means the numerator represents the patients we don't want counted, patients with poor control or missing information, so a lower score is better. Here's how to think about it in the clinic. The denominator is adults 18 to 75 with a documented diabetes diagnosis who had at least one eligible visit during the measurement period. The numerator includes patients whose most recent glycemic status assessment during the year is either greater than 9%, or missing because it wasn't performed or wasn't recorded in a way the measure can recognize. The measure allows either a traditional A1C or a glucose management indicator, or GMI, as long as it's documented correctly. So for clinicians, every patient with diabetes needs 2 things over the year. 1, timely testing, and 2, making sure the result is captured correctly so it's not treated as missing. Now let's talk documentation, because this is where most performance gaps happen. To count for this measure, the glycemic status assessment must be documented as a percentage in a structured field. If it's in a scanned PDF without discrete data, the system often treats the test as missing, and missing counts against us. For clinical staff and MAs, the workflow is order the test, confirm it's completed, and confirm that the result comes into the EHR in the lab results area, not just as a scanned document. For data teams, monitor how many diabetic patients have an A1C or GMI that is missing, because missing is automatically numerator negative for this inverse measure. One important technical detail: if multiple glycemic status results are recorded on the same date, the measure uses the lowest result for that date. So if a patient has 2 values documented the same day, the lowest value is what counts. This next measure is depression screening and follow-up plan, Quality ID 134. The denominator includes patients 12 years and older who have a qualifying encounter during the year. One key exclusion: any patient with a prior bipolar disorder diagnosis is excluded from the measure, regardless of whether the diagnosis is active today. For numerator compliance, 2 steps are required. First, the patient must be screened for depression using an age-appropriate standardized tool either on the date of the encounter or up to 14 days before the encounter. Second, if the screen is positive, there must be evidence of follow-up. Follow-up must be documented on the date of the encounter or up to 2 days after the encounter. Here's the key: 2026 refinement. The numerator now also includes patients who have an active depression medication that overlaps the date of the qualifying encounter. In other words, if the patient is already on an active antidepressant and it overlaps the encounter, that can satisfy the follow-up component for the measure. CMS also clarified guidance to reduce confusion around multiple screenings and what qualifies as a screening tool versus a diagnostic tool. Here's what we need to do operationally, so depression screening counts. Step 1 is the screening itself. MAs, nurses, and clinicians should use a standardized tool like PHQ-2 or PHQ-9 and document the result in the structured screening fields. The date matters. It must be on the encounter date or within the 14-day window. Step 2 is follow-up for any positive screen. For 2026, there are 2 ways to satisfy numerator follow-up. Document a follow-up plan within 2 days or ensure there is evidence of an active antidepressant overlapping the encounter. What counts as a follow-up plan? Examples include referral to behavioral health, a safety or crisis plan, counseling or coping support, medication initiation, or scheduling a follow-up visit. The key is that the follow-up is documented and tied to a positive screen. For care coordinators, if a positive screen is recorded without documented follow-up, Use your work queue to close the loop within the 2-day window. This is a perfect handoff point. For data teams, monitor how many positive screens have follow-up documentation versus medication overlap, so we can identify where workflow breaks are happening. This measure is controlling high blood pressure, quality ID 236. The denominator includes adults 18 to 85 with essential hypertension that started before and continued into the measurement period, or started during the first 6 months of the measurement period, and who had at least one visit during the year. The numerator is met when the patient's most recent blood pressure during the measurement period is controlled, meaning systolic under 140 and diastolic under 90. A critical guidance point: only blood pressures taken by a clinician or an automated device are acceptable. Remote monitoring values can count if the device is capable of transmitting data, or if the clinician determines the device and reading are reliable. And one more important rule: do not use blood pressures recorded during an acute inpatient stay or in the emergency department. Those should not be used for numerator compliance. Here's how to operationalize blood pressure control so it counts. First, blood pressure must be entered in discrete vitals fields, both systolic and diastolic, so the measure can read it. Second, if the initial BP is elevated, recheck it during the same visit whenever clinically appropriate. The reason is simple. The measure uses the most recent BP in the measurement period, and the last documented BP can make the difference between controlled and uncontrolled. Third, avoid copy forward vitals. Copy forward can cause invalid readings to persist and can create audit issues later. Fourth, if you're using remote monitoring, make sure those values are still landing in structured vitals fields and that the process confirms device reliability per clinical discretion. For QI teams, this measure improves fast with 2 tactics: repeat BP protocols and standardized staff training on entering a final BP. For data teams, build monitoring to flag patients whose last BP for the year is above target so outreach can happen. This is breast cancer screening quality ID 112. The measure looks at women 40 to 74 years of age and checks whether they had a screening mammogram in the 27 months prior to the end of the measurement period. The CQM reporting strata include women ages 42 to 51 and 52 to 74, which helps CMS report the results in standardized age groups. One important guidance reminder: this measure evaluates primary screening. Procedures like biopsies, breast ultrasounds, or MRIs do not count as the screening event for numerator compliance. For breast cancer screening, performance usually comes down to one operational issue: capturing screenings done outside our system in structured fields. A mammogram counts when the date and procedure are recorded in a discrete screening or procedure history field. If the mammogram was done externally and only a scanned report is uploaded without discrete date documentation, it may not close the care gap. For clinicians and MAs, when a patient reports an outside mammogram, ensure the team enters the screening into discrete history with the correct date. For care coordinators, use outreach lists for patients approaching the 27-month threshold to schedule imaging early. This is colorectal cancer screening, quality ID 130. The measure evaluates adults 45 to 75 and determines whether they have evidence of appropriate colorectal cancer screening based on the screening modality and time frame. The specification also clarifies what should not count. Digital rectal exams and office FOBT tests performed on samples collected via DRE are not appropriate screening methods for numerator compliance. Since this measure is being phased into APP Plus for ACO reporting beginning in 2026, it's especially important that clinics have a strong registry and documentation workflow. CRC performance is primarily an operations and tracking measure. Most failures happen when screenings occur, but the dates are not captured discretely, especially for outside colonoscopies. To get numerator credit, the screening type and the completion date must be stored in structured fields that the measure logic can read. Here's an effective FQHC workflow. First, run a registry of patients due for screening. Second, during outreach or visits, offer screening options and place orders. Third, track completion, especially for fit kits and referral colonoscopies. Finally, ensure the completed screening is entered discreetly so the care gap closes in the EHR and in reporting. For care coordinators, this is one of the best measures for centralized outreach because tracking and follow-up directly drives completion. Now we're moving into patient experience. CAPS for MIPS, Quality ID 321. This is different from the other CQMs because it's not calculated from the EHR. It comes directly from how patients respond to a standardized survey about their experience receiving care. For FQHCs, CAPS is best understood as a whole clinic measure. It's influenced by what happens before the visit, during the visit, and after the visit, not just the clinical encounter itself. That includes phone access, front desk interactions, clarity of provider communication, whether test results are explained, and whether follow-up steps actually happen. CMS has continued modernizing the survey approach, including adding web-based options in MIPS CAPS, so patient expectations for convenient communication and access are only increasing. The key point for teams is, CAPS performance improves when we treat experience as a workflow, not a personality trait, meaning we standardize access, communication, and follow-through at every touchpoint. Next is Quality ID 479, hospital-wide 30-day, all-cause unplanned readmission, also called HWR. This is a claims-based outcome measure. That means it's calculated by CMS using administrative claims. It's not something we submit from the EHR the way we do with eCQMs. Even though it's claims-based, FQHC teams have major influence over it because readmissions are often driven by predictable issues: medication confusion, inability to obtain prescriptions, lack of timely follow-up, unmanaged symptoms, or missing support at home. For practical purposes, think of readmission prevention as a 30-day process with two high-risk windows: the first week after discharge, and then the remainder of the month where gaps in care, transportation barriers, or symptom escalation can bring a patient back to the hospital. Now we're on Quality ID 484, risk standardized hospital admission rates for patients with multiple chronic conditions. Like HWR, this measure is calculated from administrative claims, not from EHR data submission. It focuses on admissions among patients with multiple chronic conditions, and it is risk standardized to better compare across organizations. CMS also finalized refinements in 2026 to improve consistency in measurement across ACOs, which means some organizations may see small shifts in trend comparisons year to year. For FQHC teams, the best way to influence this measure is not through documentation. It's through proactive chronic care workflows, timely access, medication management, patient education, and early outreach when symptoms begin to worsen. Before we wrap up, let's zoom out and look at the full list of PY 2026 MSSP CQMs included in APP+. This table summarizes each measure by quality ID, title, measure type, and how it is collected. First, we have the eCQM measures. These are pulled from the EHR, and success depends heavily on structured documentation. These include Quality 001 Diabetes A1C Poor Control, which is an inverse intermediate outcome measure, meaning missing labs or values greater than 9% count against us. Quality 134 Depression Screening and Follow-up. This measure includes specific timing rules for when screening and follow-up must be documented, and CMS updated the numerator logic in 2026. Quality 2, 36. Controlling high blood pressure, where performance is based on the most recent BP recorded, and it has to be documented in discrete vitals fields to count. Quality 112, breast cancer screening. Based on a screening mammogram within the look-back window with specifications aligned in the 2026 eCQM version. And Quality 113, colorectal cancer screening. This is an important highlight because it is phased into APP+ beginning in 2026, meaning sites need strong registry and documentation workflows to ensure screenings count. Next, we have CAPS, Quality 321, which is a patient experience survey. This is not pulled from the EHR. Performance is driven by access, communication, follow-up, and the patient experience at every touchpoint. Finally, we have two claims-based outcome measures: Quality 479, the 30-day hospital readmission rate, and Quality 484, admissions for patients with multiple chronic conditions. These are calculated from administrative claims, so you don't directly submit data for them, but our day-to-day workflows around transitions of care, medication access, and proactive chronic care management directly influence performance. Slide is the Take Action Summary, what each role can do starting now to improve performance for 2026. First, close care gaps early. Don't wait until the end of the year. Use registries and visit planning, so screenings and labs are scheduled and completed with enough time for follow-up. Second, use structured fields. For the ECQMs, if the result lives only in narrative text or a scanned attachment, it may not be recognized during extraction. The goal is to capture the key elements, like blood pressure values, screening completion dates, and lab results, in discrete fields so they count. Third, encourage timely labs and screenings. Measures like diabetes control are impacted not only by the value, but also by whether the lab is completed and recorded. Missing results count against performance in inverse measures. Fourth, document follow-up plans. This is especially important for depression screening. CMS includes timing rules and numerator logic that require follow-up to be clearly documented, and that specification is refined for 2026. Fifth, schedule 2 to 7 day post-discharge visits. Even though readmissions are claims-based, we influence them through reliable transitions of care workflows, fast follow-up, medication reconciliation, and closing the loop on discharge instructions. Sixth, focus on communication and access. This directly affects CAHPS and also improves follow-through on labs, referrals, and chronic care plans. And finally, reinforce patient experience at every touchpoint. From the phone call to the front desk to the clinical encounter to follow-up, patient experience is shaped by consistency and reliability. Improving those basics strengthens CAHPS and supports overall outcomes. Thank you for taking the time to complete this training. Your documentation and workflow consistency make a measurable difference, not only in our ACO reporting, but in patient outcomes and continuity of care. If you need help with measure definitions, workflow tools, or where to document items in the EHR, please reach out to Kimberly Gonzalez at kgonzalez@bestcare.org. We'll continue providing job aids, tip sheets, and refreshers throughout the year to help make 2026 successful.